Absolutely. It's a pleasure to be here, Rob. I'm Nilesh Patel. I'm the Chief Medical Officer, or more correctly, the Vice President of Medical Affairs for the Neuromodulation Division. I have a fellowship training from Cleveland Clinic, where I also served on staff, and 26 years of clinical experience taking care of chronic pain patients before joining Boston 2 years ago. Yes, we had an exciting NANS series of presentations with over 20 presentations combining real world and randomized controlled trial data. We are most excited about 3 therapies: fast-acting subperception therapy, about combination therapy, 2-year data that provided deep and durable relief, and our relationship with IBM research that specifically uses artificial intelligence, machine learning, and deep learning to better understand the patient and to potentially predict the patient's pain and address the pain preemptively. Yes, this is our 6th year working with the IBM research team. Essentially, we're looking at studying the patient beyond just understanding the pain when the patient visits us. So as a pain physician, I would see the patient, ask the patient when he visits me, what happens, to the pain, what the pain score is. And generally, you only have a single data point, and then perhaps you see the patient every 3 months, 6 months, and so forth. And you don't really know what happens to the patient in their home setting. So using a combination of questionnaires as well as wearable information, you can understand the patients from multiple perspectives, including alertness, activities of daily living, medication use, mobility as measured objectively, mood, sleep, and pain. And you have multiple data streams that allow you to better understand the patient. And based on that, you can personalize the patient's therapies going forwards. So as a clinician, I would understand the patient better. And if you imagine that there is a fog in terms of what goes on in the patient's lives outside of the clinic, that fog is now being lifted. Yes, pain is complex and pain changes over time because of neuroplasticity. So no 2 patients are the same. Each patient needs a customized therapy and a therapy that is going to change and adapt as the patient's pain changes. And having a combination therapy, as we do, we have been able to validate that the patients do need multiple options, customized to their need and their time. And our 2-year combination therapy data, which was the randomized controlled trial data that we presented at NANS, shows that 85% of these patients are responders, so they'll get at least a 50% pain relief. That there was a marked improvement in function with the measure of Oswestry disability score changing 25 points, and that the patients are satisfied as measured by PGIC, which stands for Patient Global Impression of Change, where 85% of the patients said, I'm better or very much better at 2 years. And this is corroborated by our published work from last year with 2 years of real world data in consecutive patients. And we have 420 patients in the real world trial, but we also need randomized controlled trial data. So you have 2 years of robust randomized controlled trial data, and you have 2 years of real world data that corroborates that combination therapy is superior to monotherapy. And what goes on in the combination therapy? Traditional monotherapy fails to provide long-term relief. So the traditional monotherapy would be, for example, is a single therapy. So if you combine that with the subperception therapy, combination therapy is combining a tonic therapy with a subperception therapy, then the outcomes will be much better, or that's the expectation. And now we've been able to demonstrate that indeed in real world and RCT, the outcomes are much better for these patients. So as a pain physician, if a patient comes to me, all I have is an understanding of what the patient tells me at that visit. I don't really have an understanding of what goes in the patient's life. The fact that you can collect data through questionnaires as well as through wearables, and have both subjective and objective input allows you to put all of the data, and because of artificial intelligence, you can come with specific states and understand that particular patient better. And down the road, you can then predict the patient's pain based on artificial intelligence collected states, and potentially have the patient dwell in a better state compared to where they have been. So this is collecting data en masse, but personalizing it to the patient. Yes, we also have a new therapy called fast-acting subperception therapy. And if you look at traditional subperception therapies, it takes between 1 and 3 days to wash in and to optimize. But with fast-acting subperception therapy, the patient can have relief within minutes. And so before they leave a clinic, they will know that that fast-acting subperception therapy is going to work. Our collaboration with Duke's renowned neuroscientist, Professor Warren Grill, allowed us to understand how this works. So the clinical data, as well as the bench science, clinical data to show that this therapy works, and the bench science to show how the therapy works, is something that's very exciting.